All right, everybody, this is chapter 7, which starts on page 101. This is drugs for pain control. Now, when we talk about pain, we know pain can be very unpleasant for some. It can be mild to severe, just depending on how it's interpreted. It does cause emotional problems. It can cause a lot of physical issues too. Everybody responds differently to pain, so that's why we always have to ask, what's your pain level? What the person says it is that's what the pain is, and that's what it's going to be doing. So we always ask them, what is your pain level? We rate the pain by asking, how bad is it? We can do pain intensity. We can use different scales for pain. And on page 102, are some different, on 103 are some different pain scales. Now, the easiest pain scale out there is asking them, what's your level from 0 to 1? 0 being no pain, 10 being the worst pain ever. How would you rate your pain? So that is the easiest one to use. Now, we do have the Wong-Baker face scale, and which is good for kids, because you can always ask the kid, point to what face are you feeling right now? And they're always like happy or smiling, and then they always point to the sad face, and then their face gets all sad, and it's so terrible. So you can use that, and sometimes some adults use that because they'll say, I don't know. I'm like, from 0 to 10, I just need to know where you're at, if it gets worse or not. And then, of course, on page 103, we have the FLAC scale. And the FLAC scale is good for people who are non-responsive, or your pediatric, your babies who cannot give you a scale or talk. So those are some that can help you with those individuals. Now, acute pain tells us something is wrong. Okay, well, if someone has acute pain, that's saying something is wrong in their bodies. And when we have acute pain, you're going to see changes in their vital signs. Acute pain, changes in vital signs. So you can see an increased heart rate, increased respiratory rate, also an increased blood pressure. And like I said, this only occurs for people who are having acute pain. People who have chronic pain, usually their vital signs don't change because they've had this pain for a long period of time. So that's why I'm telling you, acute pain, vital sign changes because of that. It is perceived or felt in the brain, okay, and you can read up all about pain perception and how it works. Pain threshold, that's the lowest intensity of stimulation at which pain is experienced. When we first experience pain. Pain tolerance is the maximum level of pain a person can handle or tolerate. It's personal, it's unique. When we ask for a level, that's the pain tolerance, what they can tolerate. Now, there's 3 types of pain. Like I said, there's acute pain, which is something's going on right now. Chronic pain, someone's had it for a long period of time. And then there's cancer pain. Analgesics are the drugs people take for pain. They can be prescribed or they can take them over the counter. They are either opioids or non-opioids, usually prescribed as PRNs, which is as needed basis. Some of them are controlled substances, and these are any drug or medication that can cause addiction in a person. A controlled substance is something that's going to cause addiction. There are 5 scheduled classifications that are based on addictive powers. Schedule 1 are your most addictive, while Schedule 5s will be your least addictive properties. And you can all see these on page 105. Okay, and you can look at the different schedules that they have. The majority of the time, if you can see, when we're giving any type of pain pill, we're going to be more in the Schedule 2 category. Okay, and some of the things that they send home to you could be Schedule 3. But usually your street drugs are a Schedule 1 category. And then there's some drugs that are more for like diarrhea and things. Those are going to be like Schedule 5s. And cough syrups and that. Schedule 2 and 3s closely are watched by the federal government. A prescription, I talked about the DEA number. Every physician has a DEA number, and that is given by the Drug Enforcement Administrator. And a prescription, any type of controlled substance, needs a DEA number. Without a DEA number, the prescription cannot be filled. Drugs must be locked up. They must be tracked. Any controlled substance has to be locked up and tracked. It should be counted every shift to make sure it is correct. And if you're going to waste part of that narcotic, you need 2 people to waste it. So there are 2 nurses need to waste a drug in order for it. That count has to be Very, very watched and careful. Because if it's not, then they're going to look, things are going to look suspicious. They're going to start looking for drug use or abuse. There's a lot of stuff that can happen. So that's why it's very important for us to monitor the narcotics very closely because things are monitored. Now, like I said, with the DEA number, doctors have to put that on. A lot of times if they're not on there, I always like I said before, but without that DEA number on that prescription, people try to get bottles and bottles of narcotics. And then that's usually a lot of times how the pharmacist realizes that it's not legit because there's no DEA number on it. And then they can call the police, or they can even call that provider to say, hey, did you forget a DEA number? So that is why we, they look for those things. Because narcotic and that are very, very serious, and it's high risk for addiction. And remember, narcotics is one of our pinch drugs. It's the end, so it can cause a lot of harm to a person. So before we give any of these medications, we always want to check a pain level. We want to check a pain level before to see if the medication is going to be working after. We want to see if we have an order for something for pain. Is it time for them to have that medication? If we give too early, we can cause increased side effects and adverse effects. If we give it too late, people can suffer more. But if the medication says give it every 8 hours, we have to give it every 8 hours. So if it was given at 12 o'clock, then we're going to give it at 8 o'clock if it's every 8 hours. And we're not going to give it at 7:59. We're not going to, give it at 7:45. We're going to give it exactly at 8 o'clock. If it says every 8 hours, it has to be every 8 hours if it's an as-needed basis. It will increase, like I said, side effects and adverse effects. We have to watch for those. If it is ordered routine, then we can give when due. Sometimes we have to wake the patient up. Even though they're sleeping, we have to wake them up to give them that pain pill. It's very important always to check vital signs. You can tell the patient to call late for assistance if they're getting out of bed because we don't want them to get hurt or fall. Afterwards, we're going to re-ask them what the pain level is and what the scale is. Did it help? Did the medication help you? Check the level 30 minutes and then an hour after you give that medication until you're able to give the next dose. So we always want to ask them, how's your pain level doing now? How is your pain doing now? Teach the patients about addiction, that it can occur if you don't take it as prescribed. Ask for pain medications only if needed. Sometimes we have to remind the patient to don't wait too long to take a pain medication, because if the pain gets too severe, it's going to take some time for that medication to kick in. So sometimes we do have to educate them. If you're, don't let that pain get bad. Take a pain pill. You have it prescribed. As long as you're taking it as ordered, it will not become addictive. Now, when we're talking about opioids or narcotics, these are from the poppy or similar synthetic chemical. They do help change the person's pain perception. They are very, very, very addictive. They can cause psychological as well as physical dependence. It is a prescription drug. It can be a Schedule II drug. Like I said, it's our high alert drug. It is the end in our pinch, so it can cause harm if given wrong. Besides pain, it can help control coughing. It can decrease diarrhea. It can decrease respiratory problems for terminal patients. So it can do a lot of things. So that's what we want. Now, drug tolerance happens with long-term use. The body gets used to the med and it gets rid of the drug faster, causing the person to feel like not getting any relief. And then they have a decreased side effects. So they need to be put on stronger doses of the pain med to get that pain relief. Or sometimes they'll increase the times of the day. They'll keep it the same dose, but give it more often. So instead of 3 times a day, we're going to give it 4 times a day, because over time, people can build up a drug tolerance to some things. Some opioids are combined with other medications, such as Tylenol, aspirin, or NSAIDs. On page 107 are some of our common opioids that we give. And you can see morphine is the big one, morphine. Hydromorphine, which is Dilaudid. Everybody likes the Dilaudid. Then we have, we do not give much Demerol anymore. Meperidine, we don't give much of that. Codeine, we do give codeine. Usually codeine, when we give it, it's mixed either with cough syrup or it's mixed with the medication like Fentanyl is a big one that we do give. They do have lozenges and lollipops and patches for fentanyl. So a lot of times, like cancer patients, will give a fentanyl patch, or they'll even give them a lollipop, which has fentanyl in it to take. And we have oxycodone, and then we have our mixed one. We have oxycodone with aspirin, which is Percodan. We have oxymorphone, hydrocodone, which is Vicodin, which we don't give too much of. Hydrocodone with Tylenol, which is Vicodin there. Tramadol, which is Ultram, which is another medication. So those are some of the meds that we would give that are called opioids. Now, morphine is the classic opioid. Opioids do work in the brain, so it does affect the brain. Opioids only alter the perception of pain. They have no effect on the area where the pain is located. So if you have a cut, it's not going to do anything with the cut. If it's all up in the head, that's where the pain perception is. Now, side effects. The biggest side effect for opioids is constipation. They can have nausea and vomiting just due to the decreased motility, because opioids will slow your GI system down. You can have flushing and skin itching just due to the dilatation of the blood vessels, and stronger doses can cause drowsiness. So sometimes people do get a little drowsy with these medications. So we always recommend them to not drive or operate heavy machinery or to drink while they're on these medications. Big adverse effect is respiratory depression. You'll see more often when you give it IV, but it can cause it. So that's one big adverse effect. Addiction is another adverse effect. Dependence is another adverse effect. And withdrawal. And withdrawal is a symptom that occurs upon the abrupt stopping or discontinuation of a medication. One must first develop a physical or mental dependence before you can go through withdrawal. And usually with that, withdrawal symptoms from narcotics, they will have nausea and vomiting. They will actually have abdominal cramping, sweating. They will have deliriums, and they can also have seizures. So those are some things to watch for. We will see more people who take opioids for for psychological high and not for pain. So a lot of times people take it for psychological highs, just to get the high feeling than actually for the pain perception itself. So before we give opioids, we want to check a name and dose of the medication. We want to check a respiratory rate and O2 saturation, because it can cause some degrees of respiratory depression. After we give the opioid, we want to check the respiratory status. The respiratory rate and O2 saturation we want to check. If the respiratory rate, this is important, if the respiratory rate is less than 8 and the patient is sleeping, call their name and try to wake them up, okay? If they're still not responding, you may have to shake them harder. So you call their name, now you're shaking them to see if you can wake them up. Or you can use some other techniques like squeezing the trapezius muscle. Sometimes you can apply pressure to their nail beds. If they are not responding, you may have to call for help. If the O2 saturation is below 95% or 5% points below person's normal saturation, arouse the patient and check a level when they're awake. If saturation is low, then apply oxygen and notify the doctor. If we need to reverse opioids quickly, we can give them an opioid blocker or an antagonist, okay? And we know a big one that we give that people can give it out on the streets. Cops give it. You can get it if you go to the health department, and that would be naloxone or Narcan. Narcan will reverse opioids. These meds will displace the opioids from the opioid receptors on the cells. With the opioids off the receptors, the opioids are reversed in about 1 minute. Your breathing will be better, but patients will experience pain because it reverses these effects. So if the patient has been on these for a long period of time and we've reversed it, then we have to watch for those withdrawal symptoms. So that's something we have to watch. Patients, and then we have to monitor these patients for several hours afterwards, because they can actually go back into respiratory depression and not breathing and things like that. So those are what we have to watch for. So we monitor after to make sure everything's okay. Patients can become drowsy with these meds, and they can be risk for falling. So we want to make sure we have them use the call lights. We want to make sure that they call for any help, and say, please, please, if you're going to get up, let me at least assist you to the bathroom. Always ask if they're on it for a period of time about constipation. If they're on the meds for more than 2 days, we may offer them some stool softeners or laxatives. We want to check a blood pressure. We want to make sure they change positions slowly because it can cause orthostatic hypotension. We want to teach your patients about opioids. Take them with food to decrease nausea. Inform that they can become drowsy, so don't operate heavy machinery. They become dizzy or lightheaded, so move slow when changing positions. And definitely want to give them signs and symptoms, signs and symptoms, ways to prevent constipation. And that would be like drinking 3 liters of fluids. We want them to get more fiber in their diet, and we want them to exercise. So those are some ways to help with constipation. Now, the pediatric population, dose of the med is calculated by different factors. It's hard to tell if they're having pain or not. They can have the same side effects as adults. We need to prevent constipation, and we need to definitely watch for respiratory depression in our pediatric population. Pregnant or breastfeeding, it can be given during pregnancy. They do cross the placenta. The fetus can become addicted, and they can go through withdrawals when born. If drug is stopped several weeks before birth, then baby is born without side effects. And respiratory depression, we know that we need to give naloxone or Narcan if they do have issues. But hopefully, if the drug is stopped several weeks before birth, the baby won't have any side effects. But if they have respiratory depression, if they were on meds, then they may need to give that naloxone to the baby itself or the Narcan. Breastfeeding is not recommended if you're on opioids for a couple of days, so they do not recommend that. Now, the older population, low vision, their pupils get smaller. So anytime they have low vision or the pupils get smaller, they're at high risk for falls. So we need to tell the patients to turn on the lights. Our older populations need to turn on the lights to see when they're walking. That's very important. They said if they take meperidine or Demerol, they can complain of chest muscle tightness, which makes breathing and coughing more difficult. And this can lead to pneumonia or hypoxia. We need to definitely watch the respiratory status. And we know that meperidine or Demerol can cause the buildup of toxic metabolites, which can cause seizures. So we should not give this med to the elderly population. And we really don't give Demerol anymore. That's one of the drugs. They still have it out there, but it is not a drug that we give at all in the emergency room. We used to give tons of it, but not anymore. So that is the opioid part. So the reversal for opioids, which is the antidote for any opioids, is naloxone, which is Narcan. So that's something that you need to mark down on a sheet of paper, something marked down, because I do like reversals and they will come up on test. Or antidotes, you can call them. Now, when we're dealing with non-opioid pain control, these can reduce person's perception of pain without the narcotics and the addictive properties. Sometimes they are combined with narcotics to enhance pain control. A big one is acetaminophen, which is Tylenol. It works well for pain. It works on the brain to change the pain, and it will decrease the pain receptors. It comes in different forms. It can be bought over the counter. You definitely do not give more than 3 grams per day. Sometimes you'll see the doctor write 4 grams. So I always put 3 to 4 grams a day, but 3 grams, you should not give any more Tylenol. And remember, other medication contains Tylenol. So when you're giving people Tylenol, you always want to include the meds that contain Tylenol in it. So that's important. With high doses or overdoses of Tylenol or acetaminophen, it can cause liver damage or kidney damage, and increase if you take with alcohol. Okay, alcohol affects the liver, Tylenol affects the liver. So you should not drink alcohol if you take Tylenol, big time, because of the liver damage that can occur. So we have to watch other over-the-counter meds, like I said. Anytime someone overdoses with Tylenol or acetaminophen, we will give something called acetylcysteine or Mucomyst. And this is the antidote for Tylenol or acetaminophen overdose, is acetylcysteine or Mucomyst. It's to help save the liver. We need to give it within 24 hours to be effective. We can check to see if a patient actually overdosed on acetaminophen by doing acetaminophen level. So we can check and see how much Tylenol or acetaminophen that they took. But like I said, acetaminophen, you cannot drink alcohol with it because it will increase the risk for liver problems. And that is very, very big with acetaminophen. And like I said, people who overdose on it, we have to prevent that liver from damaging. So that's why we give the acetylcysteine or Mucomyst. And we have to get them in within 24 hours. Acetylcysteine or Mucomyst smells like rotting eggs. We also give it, it's actually, we're going to learn about it in the respiratory chapter. It's actually a mucolytic, which will help with asthma patients or COPD patients to help with the mucus that they have. And they will actually inhale it. But we usually give it IV, and then afterwards they will have to drink the oral dose of Mucomyst. And a lot of times, like I said, it smells like rotting eggs. So sometimes we will mix it with cola and that so they can take it to prevent that liver damage. Tylenol, drug of choice, also for people, or acetaminophen or Tylenol is the drug of choice for anybody on any anticoagulating therapy. We don't want them to take aspirin, like if they're on Eliquis, if they're on Plavix. We do not want them to take anything but acetaminophen or Tylenol for pain. We do not want them to take aspirin. Now, NSAIDs or non-steroid anti-inflammatory drugs, they also help with pain related to inflammation. It does work on the site of pain, and we talked about that in the last chapter. It helps with inflammation as well as pain. How many times do we take ibuprofen or, Advil or Motrin? We take that a lot. Naproxen, we take a naproxen for pain. So those are some of the things that we can take. Also the Now, there's also some antidepressants that we use to help with pain. They're found to decrease some types of the chronic and cancer pains. These drugs increase the natural opioids in the brain as well as decrease depression related to pain. So amitriptyline, which is Elavil, nortriptyline, which is Pamelor, paroxetine, which is Taxol, or sertraline, which is Zoloft. All those ones we can use for pain. Now, anticonvulsants are also found to reduce some types of chronic or cancer pain. They're good for nerve pain or migraine headaches. They can reduce the rate of electrical transmissions on sensory nerve for pain. Usually the doses will be higher for pain than for seizures. An example of that is gabapentin or Neurontin. And pregabalin, which is Lyrica. Those are some of the medications like gabapentin we use a lot. We don't use it a lot for like the seizures because gabapentin is used for seizures. It is a drug, but you don't usually see it much used for that. It's used more for like neuropathy pain or any type of nerve pain. And you'll see that like with our diabetics who get diabetic neuropathy, they will be prescribed gabapentin or Neurontin. And also another thing that will help with pain is muscle relaxants, which will relax the skeletal muscles, which also will help with pain. And that is something that we are going to learn in future chapters when we deal with the skeletal muscles. So that is basically pain. So basically remember a few things with that. The narcotics, it is a pinch drug. Okay. We also know that the reversal for opioids is naloxone or Narcan, which is, we give a lot of that. Also, we have to remember that if they overdose on acetaminophen, we were going to give acetylcysteine or Mucomyst to that patient to help save the liver. We know also that liver is affected by Tylenol and alcohol. So we do not want to take those two things together. And anybody who's on any type of coagulating drugs, we want to just make sure that they take I can't even talk. Acetaminophen, which is Tylenol. So that is chapter 7? Chapter 7 of our book. Any questions, give me a ring.